Welcome to this special Skin of Color Savvy, the art and science of treating patients with skin of color, the official podcast of the Skin of Color Society. This podcast is produced by HCPLive and hosted by Skin of Color Society leaders. And the Skin of Color Savvy is really delving into the latest research, clinical insights, and culturally intelligent and responsive care practices in dermatology with leading experts. My name is Raj Chovatiya. I'm an associate professor at the Rosalind Franklin University Chicago Medical School and founder and director of the Center for Medical Dermatology and Immunology Research. And it's really fun to be here presenting this very special episode live from Revolutionizing Atopic Dermatitis in beautiful Nashville, Tennessee in 2025. Before I further ramble on, I would love my co-host to introduce herself.
I'm Dr. Tiffany Mayo. I'm an associate professor at the University of Alabama at Birmingham. I'm also director of our clinical research unit there. It's a pleasure to be here with you all live today.
So we're going to be spending the next half an hour or so talking about a subject that is near and dear to both of our hearts, really thinking all about atopic dermatitis, skin of color, and maybe even asking bigger questions about atopic dermatitis diversity. What is it all about? Where are we? Where have we been? And where are we going? Yeah. And, I think maybe a good place to start is the question that always comes up. What are some of the reasons why atopic dermatitis seems to be under-recognized in some groups? And obviously, I'll maybe ask you, Tiffany, about patients with skin of color, but even more broadly, why do we have disparities in recognition of atopic dermatitis?
I think, that's a complex question because there are so many avenues we could really explore here. But one of the main ones is recognition is based on what we have seen in the past often. And so there have not been a lot of clinical images of atopic dermatitis and skin of color. So that's one big area. Another one I would say is that the way that we see clinically atopic dermatitis in our current photos, one of the first clinical signs is erythema. And so that's where a big challenge is going to come in with our skin of color patients. So one, lack of clinical images, but then also in those clinical images, really we emphasize the erythema, which is also something that is not going to be seen as well in our skin of color patients. So that really starts to get at the disparities that we see in our awareness and diagnosing atopic dermatitis in skin of color patients.
Well, inherently, we're such a visual specialty with dermatology, and oftentimes from the actual opening of the door, the first thing we're doing is taking a look at what's going on, and our mind's being like, okay, is this a 5-second diagnosis type visit, or is this one we're gonna have to sit and talk a little bit? And I think for too long, atopic dermatitis we used to think was, you know it when you see it, and that's eczema, and you don't really have to spend that much more time figuring out what's going on. And particularly in patients that perhaps you may not be attuned to seeing that often, it might be a little more difficult than that. And so I love your point about erythema being one of those things that probably has a role in people's ability to recognize the disease, also people's ability to appropriately grade the severity of the disease. Don't forget there's other skin changes too in terms of postinflammatory pigment alteration that can sometimes be mistaken as part of the disease's active process. It may not be thought of as sort of an after effect of the disease. That can probably muddle the situation
Absolutely.
too. And then, while not necessarily the entire focus of today, thinking broadly about our patients that perhaps have less resources than others, their ability to actually seek out people in the dermatology world to help them that understand what's going on, that can maybe give them an appropriate diagnosis and an appropriate medication is another reason why there's probably a lot of disparity there.
I agree 100%. So patient awareness of atopic dermatitis as an actual medical condition is not where we need to be. So there's still a gap there, and that leads to disparities because patients don't actually know that their disease that they are dealing with, that they may think is dry skin, that it actually is atopic dermatitis and that we have excellent treatment options for them.
I feel like it's a perfect study waiting to be happen, but I always love looking at the comments section of the patient that's a new patient coming to see me, and what does it say? And oftentimes it says dry, itchy skin, right? And the question is, I always ask myself, is this a new patient with eczema coming to see me, or is it something else? And I feel like there's other reasons why, but oftentimes that is the singular reason. And it's somebody that may have had it for a long time, but they are not aware of the terms eczema, atopic dermatitis, dermatitis or anything that really describes their condition.
I agree. Then there's also this thought that is just dry skin, and so especially when we're talking about skin of color, this idea that, skin of color patients have dry skin. And so then we may be missing atopic dermatitis from a clinical standpoint, but also the patients may assume that their skin changes. It's just dry skin that they see. They may even have other family members. And so they're kind of more normalizing atopic dermatitis and the itch, the symptoms that go along with it. They're so accustomed to it that it may not be something that they realize can be treated.
It's true. I mean, this point about xerosis or dry skin, oftentimes people are so attuned to it because it's another one of those features that actually is highly visible when your background skin tone is quite dark compared to someone with lighter skin. And so that's immediately what you're drawn to. And that may not be exactly what's going on. It might be part of a chronic condition. So I probably would raise a lot of points that we could each do an entirely separate podcast on, but maybe we can go a little deeper into this question about not only the active disease, but the after effects. And I talked about this post-inflammatory pigment alteration, or what people might know as post-inflammatory hyper or hypopigmentation. How does that affect our patients with skin of color?
Significantly. So I actually encourage every one of you to, when you're seeing patients, ask them what bothers you most about your condition, whether that be acne, atopic dermatitis, all of the things that we treat, and you may be surprised. So in our skin of color patients, sometimes the dyspigmentation is the thing that bothers them the most. And I think for a long time in dermatology, we really focused on that's secondary. We've kind of dismissed it, honestly. And many people think, we're going to treat the active disease. We don't even need to address the post-inflammatory hyperpigmentation at all. But now the patient, this is the thing that's the most important to them. So they're feeling like what you're giving me is not working. Sure. So that affects compliance, that affects, the patient's trust that you are listening, to them and their concerns. So the post-inflammatory hyperpigmentation is a huge burden for our patients with skin of color, and it's a challenge to treat. So a lot of counseling and helping patients understand that the post-inflammatory changes are a part of the disease process, that the medications that we give them didn't cause the post-inflammatory hyperpigmentation. That comes up a lot. So there's a bit of counseling that needs to happen, but also from a physician's standpoint, we also need to recognize how important it is to our patients and develop a plan of discussion of when they can expect it to start to improve, or if we have treatment options that we feel may be appropriate and not worsen their atopic dermatitis, we start to offer some of those to our patients.
I feel like I often get this question from my patients about, okay, that's great, you're recommending me a treatment for eczema, I have eczema. What can you give me for the dark spots, right?
Yeah.
And it's kind of, you face this existential dilemma of, well, treating the disease and giving time should probably help, but this patient's really asking for something. What do you do in situations like that?
It's even more difficult in patients with sensitive skin because some of the more common things that we use may actually have known irritation as a side effect.
Creating more post-inflammatory,
and worsening, atopic dermatitis flares. So it actually can be quite a challenge. So really talking about the complete regimen for a patient with atopic dermatitis, because sometimes it's not just treating the skin disease itself. It's about the skin barrier. It's about helping them understand how to take better care of their skin, better moisturization, less irritating, products that they're using that are contributing to the post-inflammatory hyperpigmentation and worsening of the disease. Now, there are some good products that are a little bit more gentle, but, each atopic dermatitis patient is going to be different in what products they may be sensitive to. But I often do incorporate some of those products, kojic acid, niacinamide, thiamidol is a new one that can be helpful for those patients.
It's a great point. I feel like at the end of the day, it's sometimes very easy to stick to the rigid textbook. Nope, this will get better. Give it time. We're only treating the disease. And, that might buy you a little bit of time, but, it's another problem with the way the textbooks are written. I feel like they still all say that PIH is really a problem that resolves on the order of weeks to months. And right? Exactly, right? I still feel like that's what it says. Yeah. And I tell my patients, we're talking months and months, maybe years. Like, it's not a very short-term thing.
I say at minimum 6 months. So 6 months to a year is where we may start to see improvement. I'll add azelaic acid. It tends to be tolerable for patients who don't have a lot of barrier disruption with fissures. But I do, counsel patients that this is going to be 1 year, 2 years that we're looking at improvement here.
For sure. And, I think that the question, we talked about erythema, we talked about postinflammatory hypopigmentation, some of the changes that we might expect to see that are more highly visible in somebody with richly pigmented skin versus not. So that brings up a bigger question, and maybe one that we may feel differently, we may not. Do you change your approach to diagnosis or grading of severity in somebody that walks in that, let's say, is much lighter versus medium skin tone versus maybe my skin tone, your skin tone, even sort of more darker skin tone? Is there anything different about what you do?
Not really about what I do. It's more about recognizing that there's going to be a difference in the way I'm going to see clinically atopic dermatitis, in this patient. So I'm going to do the same type of workup for the patient, but just realizing that what I'm going to see in a darker skin tone is going to look different than active disease, in a lighter skin tone. So another thing that I do actually is I add some of those patient-reported outcomes that are a little bit easy to incorporate into our clinical
So you're
practice.
one of the 5 people in the country that does that? Yeah, right.
But the poem score doesn't take that long to do. I work with residents, okay, so they help me out a little bit. But now that starts to help us understand the impact of disease. So maybe what we clinically see is not visually severe, or we're not seeing the erythema that is actually there but may look like hyperpigmentation, but something's not adding up about this patient's poem score being so high if they have such minimal disease. So that starts to kind of give us clues about how we need to address that person's atopic dermatitis.
Yeah, I guess you and I do kind of see eye to eye on this. I just teasing you. I also am a big proponent, and I will say this loudly anytime the group gets together, I don't think we need new guidelines or new diagnostic tools. I think people need to just step up and be a good doctor, be a good clinician, and understand the patient in front of you. Atopic dermatitis, generally speaking, is going to be the same types of barrier issues and neuronal issues and microbial issues if you go everything down to the surface. So the clinical presentation is going to be heterogeneous, and one of those dimensions is the background tone of the patient coming in with you. And it's really just about training yourself to understand how to see a human being, I guess, is maybe the way to think about it in the case of atopic dermatitis. And I say that slightly in jest, but in all seriousness, remember, it's a multidimensional disease. Signs, symptoms, course, comorbidities, these are all tools you can use to help diagnose the disease. And so if it's a patient that you feel like looks like the textbooks that you've studied forever that are really light skinned with very fire engine red erythema, that's great. But if it's someone that you may be a little less comfortable with because it's not the standard of your population or the way you were trained, think about those other dimensions, but you can really be pushed in the right direction. Okay, this person has itch and sensitivity. They talked about a waxing and waning course. They talked about comorbidities that fit into this type 2 inflammation realm. It sort of feels like atopic dermatitis. And I think that those clues are really what push you in the right way.
I agree.
What about some of the other mimickers? Do you feel like those are a little bit more challenging in people that might have background differences in skin tone? We know from studies around the world, and I think some people associate this with skin tonation. I tend to think it's probably a bit more about the exposome and environment. We know that there's higher rates of lichenoid papules and follicular types of eczema and other presentations on the extensors as opposed to the flexures around the world. Are those things that go into your calculus?
They do. I actually use a lot of dermoscopy. I love dermoscopy. I do trichoscopy of the scalp. I obviously do pigmented lesions, but I think we underutilize it for inflammatory conditions. And so utilizing dermoscopy really helps you understand the morphology and those features that we see in, for instance, lichen planus versus more of a, lichenoid atopic dermatitis picture. Or, many other mimickers that you can see, the morphology is more visible under dermoscopy. And also, a little clue is that erythema can be seen on dermoscopy better in skin of color than what we may be able to see with the naked eye sometimes. And so you can identify those active skin lesions a little bit better. So that helps, yeah.
It's a nice tip. I'd say that even thinking about just using your skills of palpation is another one too.
Yeah.
I know it seems very basic, but in addition to inspection, it's sometimes really hard to miss somebody who has just very tiny papules and a broad sheet across their back or other body areas. And you might miss the fact that, this patient has very diffuse eczematous change on their skin, especially if it doesn't look like a heavily lichenified plaque. So that's another one too. But kind of shifting gears, let's talk a little bit about treatment. And we know that most of our patients one of our number one goals we talked about at the Revolutionizing Atopic Dermatitis meeting is graduating and moving beyond this day where everybody gets topical steroids and really putting people on the right therapy for their disease and targeting it for what we know about the pathogenesis. And for many patients, probably most patients, that's going to be topical therapies. So how have you sort of started thinking about in your patients across the diversity of skin of color and every other metric you might think about for many of our newer topical therapies that are targeted and non-steroidal?
I think that's a great question, and I think it actually deserves a little bit of time to talk about the long-term trajectory of our patients in treatment and how we can, kind of make sure we're putting them on something that they can use long-term that's going to be helpful for their disease. And so we have the clinical data to back up a lot of our new topicals to show how effective they are. So now I am at an institution and I don't get samples. Yeah. So, that can be a little bit of a limiting factor to get patients started trying certain things. And then, of course, insurance can be a factor as well. But the new topicals, roflumilast, tapinarof, these are excellent treatment options that can be used long-term. Mm-hmm. They're very effective. They're tolerable, for our patients. And you don't have to, come up with these interesting regimens like we used to do with the
I hate the eczema action plan. I want to burn that because it's too many things, too long, and patients don't read it.
They don't do it, And so now we have a more simplified way. Another thing is that they often can manage more conditions than just our atopic dermatitis. And so now we have treatments that are safe, they're effective, they can be used long-term as a monotherapy in many cases. And so I really start to utilize those when I can get them covered.
I love it. And, just to kind of remind those of you out there that maybe aren't familiar with how much has actually changed in terms of the topical landscape, you heard about a couple of them. One of our newer therapies, topical tapinarof cream. This is a small molecule that's a modulator of the aryl hydrocarbon receptor. You can think about this as a family of sensors that's important for general skin homeostasis and other homeostasis in the body. Then we have topical roflumilast. This is a phosphodiesterase 4 inhibitor, important for modulating T-cell mediated inflammation. By inhibiting that enzyme, it's able to bring down inflammation, and so it's another effective option. And then topical ruxolitinib. This is a topical JAK inhibitor, works similar to the oral JAK inhibitors in terms of inhibiting this protein cascade that's important for a lot of inflammatory signaling. And each of these probably has some very unique considerations for what we might use for our patients. But I like the point you made about long-term, and I think that there's a couple of bits I want to highlight from some of these topical options that really meet the needs of what our patients are looking for, especially when you think about the amount of damage long-term topical steroids can do for patients that have darker toned skin when it comes to dyspigmentation, atrophy, and changes in that regard. Yeah. And we'll start with tapinarof because I think that's a great place to think about the fact that in the clinical trials, number one of the most diverse trial sets we've seen actually from the pivotal phase 3 trials in terms of inclusion of patients of non-white race. And so that's actually quite remarkable, and it's kind of been a guide point for how we can actually have a really diverse population in clinical trials. The other point is the design of this study, one that really tried to mirror what might happen in real world when patients get totally clear and do a really good job. As it turns out, for individuals that are managed to get their disease under control and they just kind of generally stop using therapy, they can actually go a really long time. We're talking on the order of months before they really have to restart therapy if their disease becomes mild enough again. I think that's huge for our patients that have a lot of disease burden. And I feel like it's something people have probably tried to do with every medication, but it's not something that works for a lot of other medications.
It mimics the real world scenario. I've never had a patient come back and tell me, I've used this every single day in the exact way that you've told me, for a year, so that's not going to happen. And we understand that. When we prescribe medications to our patients, we're prescribing it and we're giving them these regimens. Well, these are patients with lives. They have active, busy lives. They may have kids, they may be active in sports, depending on where the atopic dermatitis is, they may have functional issues with certain types of vehicles, so many different things. And so I think it is not realistic to think that a patient is going to use something every day. So we want that type of data that shows that a patient can be a bit inconsistent and we still have control of their disease. And so I think, that's huge for our patients.
And we've seen other designs for some of our other topicals out there. Roflumilast took a slightly different approach for people that got to really good levels of clearance. They kind of went in a proactive modality to really see that people weren't going to flare. And those data showed that people could go multiple months just kind of proactively using using it a few days a week and do a pretty good job of stopping flares. Ruxolitinib did it a slightly different way, and people went to an as-needed use during the long-term period. There, people used it about half the time as well. And so I think these are all moves in the right direction that are really going to tell us how these topicals are going to work for our patients. Since we're kind of, approaching the end of our time here together, I'd love to get your thoughts on some pearls about long-term adherence for topical therapy for our patients, with any considerations that might be important for our patients with skin of color.
Yeah, I think keeping it simple, like I mentioned, patients' lives are complex, just as crazy as our lives are. Our patients also have, things that they have to work into their lives, and they don't want to think about having to do their medication, 3 different ways throughout the week.
Yeah.
And, so keeping it simple, I think, is very important, and also giving some room for and flexibility for error. Because if a patient, if they miss one day and they're going to flare, then we probably don't have them on appropriate therapy.
Yeah.
And so I think making sure that we're adequately treating our patients, we're looking at the data, we're looking at the long-term data so that we can know what medications are going to work best for our patients. And so monotherapy if possible, but that's not always possible. I understand that, but a simple regimen is always going to work best for patients. I think another thing to consider is the vehicle. You were mentioning roflumilast, the foam vehicle, is very flexible use for my male patients with beards, who have either atopic dermatitis or seborrheic dermatitis involved in that area, or psoriasis involved in that area. So
textured hair in general.
Yes,
right?
textured hair, so the scalp, the face, wherever. So the more we have products that allow flexibility of use, different locations, safety in all those areas, I think that's the way that you improve compliance in our patient.
I like it. And I might even sort of double down this idea of intentionality, right? From the HCP side, intentionality about making this move from chronic use of topical steroids, medications that are effective but are really meant for acute use, to newer agents that have data to back up their use, and putting people on simple monotherapy that allows them to work around their life in a comfortable vehicle, in a product that's going to give them efficacy and safety. Intentionality from the actual developments of drugs in the pharma industry, right?
Yeah.
Designing trials that are diverse, that have photographs that we can show to our patients that might potentially be skeptical or confused about what their disease is and how this treatment might work. Having a diverse population, skin of color and beyond in every sense of the word, that allows us to think about all the people that might be coming into our clinic, and really having data to show us that whether you have disease itself, the after effects of disease itself, intermittent disease, this is going to be something that you're thinking about for all your patients. And so a real big hats off to what's happened in the last few years of atopic dermatitis. And I think that there's even more that we can do that can really push us to the future of where we want to go for our patients across all spectrums of skin. Any other final thoughts?
I think just really making sure that we are thinking about our patients, thinking about the disease that they're presenting with, making sure that we are aware that patients with skin of color, we may not be seeing all the disease, clinically. And so getting that extra information from those patient-reported outcomes to make sure we're adequately managing them.
Yep, I'll add my extra thought too. Think about the multiple dimensions of the disease itself. Atopic dermatitis has so many dimensions beyond just what you see. Use every one of those tools to be able to help you make the right diagnosis and the right treatment decisions for your patients across all shades of skin. So with that, thank you guys so much for engaging this insightful conversation. This is going to wrap up our episode of Skin of Color Savvy. Tiffany, thank you so much for your time.
Thank you.
This has been really, really fun. We hope that you found today's discussion informative and inspiring. If you're interested, of course, to learn more about the Skin of Color Society and the impactful work, I encourage you to visit skinofcolorsociety.org. Also, please don't forget to subscribe to HCPLive's newsletters and follow us on social media to stay up to date on the latest in dermatology and more. We'll be back with another super fun episode, hopefully with the two of us again. So be sure to subscribe to the Skin of Color Savvy on your favorite podcast platform. Until next time, thanks so much for listening.
Thank you.